Barriers, I would say there's probably three main ones. The first one is financial. Trusts at the moment get their money when patients or their GPs refer patients into the hospital, and the money follows the patient. So an acute admission, a sum of money follows into the hospital. If we stop that admission happening earlier in the patient's treatment, the hospital doesn't get the money. So you can imagine there's a financial perverse incentive. Hospitals get their money from admissions, and what we're doing is going to stop the admission because it's the right thing to do. At Airedale, we absolutely believe this is the right thing to do, and we are lobbying locally with our commissioners who support us and nationally with the Department of Health to have that tariff changed. So that would be the first one. The second one, I think, would be clinical, and it's not for everybody, but you can imagine some clinicians, some GPs, some hospital doctors don't think this is for them. They think that they have to be face-to-face with the patient. Well, they are still face-to-face with the patient through this technology. I think the term is immersive technology. Actually, once you get used to it, you actually forget that they're not in the room with you. The technology is so good, the lip sync is very good. You actually think you're with the doctor. They are in the room with you. They're in the room through the lens, and they can see and observe the same way. So clinicians who say it's not for them, once they've tried it, they then like it. And the same with the patient. You very quickly get used to it. I think the third one is about scale. So we have commissioners who want to pilot, one deployment with one patient or one nursing home. And obviously, whilst that obviously is very valuable for that individual patient or group of patients, it's not of a sufficient scale for the provider to then radically change their capacity. So for example, at Airedale, we want to take out some of our beds and reinvest that money in community, but we can only do that if we have enough scale, enough admissions avoided. Doing the odd one deployment will never get us to that point, and therefore the whole health and social care system doesn't get the benefit. So we would like to see a whole deployment, a whole scale deployment. So I guess that barrier is about commissioner confidence. Everyone wants to try it in a small scale, and we would like to see somebody do it on a big scale. Well, commissioners have got a huge challenge, haven't they? They've got growing population and ageing population. They've got to meet all of their needs with less resource than there's ever been before because of the financial challenge. So if they commission more of the same, it's not going to be enough. So they are looking for different solutions. The challenge with this, of course, is because it's innovation, somebody has to start, but there isn't a massive evidence base, particularly not in this country. And obviously some commissioners may be risk averse, understandably, and they need to know how those risks can be managed. I guess we would say we think this is low risk in terms of that, because if the patient does need acute care, we can still get them that acute care. It's just helping them further down the pathway so that we help with prevention. We help commissioners keep patients happy and healthy at home. It helps with the prevention agenda. So actually, economically, it makes sense. They will get their return on investment, but some of them want to see a lot more evidence before they're prepared to commission, where others are saying, okay, we'll develop this together. It has huge applications, as well as patients at home. Patients in nursing homes, because we're living older, longer. We're all facing a future where we're probably going to be in some kind of nursing home or a care home with social care. All the evidence says there isn't enough resource to support that. So again, this will help. It'll help keep people in care homes longer before they'll need nursing care. So it helps social services who also have the same challenge with their budget. It also helps with end-of-life care. Again, lots of us end up in hospices for our end-of-life care or at home. And this technology really helps people have the end of life that they would want to have, surrounded by their loved ones, not surrounded by high-tech equipment, but enabled by this technology. That's what it is, I guess. It's an enabler. It's not about the technology per se. It enables us to give the care that we think people want, that they would choose to have for their families. So it supports them that way. And that's what commissioners want at the end of the day, isn't it? They want to commission care for their population that meets their needs. And that's not necessarily the care that we've had for the last 40, 50 years.